Alright, today we're going to go over Fundamentals Exam 2 study guide. Run through it. It's a chemical name. Provides the exact description of the med's composition. What is the generic name? The manufacturer who first develops the drug assigns the name, and it is listed in the U.S. Pharmacopoeia. What is the trade name? Also known as brand or proprietary name, this is the name under which a manufacturer markets the med. How to classify drugs? Effect of med on body, symptoms the med relieves, med's desired effect. What is an idiosyncratic effect? Overaction or underaction or different reaction from normal. Can we delegate med admin? Nope. Alright, what does now mean? Right away, but within an hour. What does stat mean? Within 30 minutes. What are the 8 rights of med admin? Right med, right dose, right patient, right route, right time, right documentation, right reason, right response. Can patients refuse the med? Yes, they can. What's top priority when an error occurs? Patient safety. Alright, what's the easy and most desirable route of giving meds? Oral. Alright, what are the 2 routes of oral med administration? Sublingual and buccal. If we need a better absorption, what are we going to give meds with? Food. How many milliliters of fluid are we going to give meds with? 60 to 240 milliliters. Alright, what are we going to do to prevent aspiration when giving oral meds? Position them properly. So what are we going to do if we give more than one oral med at a time? Give each of them separately and flush 15 to 30 milliliters of water in between each med. So, when we're trying to give them an empty stomach, what are we going to do for oral meds? They can't eat anything 30 minutes before or 30 minutes after. Some examples of enteral meds. NG tube, G tube, J tube, small bore feeding tube. Alright, for positioning wise, how are we going to position the bed when giving enteral meds? Keep head of the bed at least 30 degrees for 1 hour after med administration. Alright, what PPE and cleaning techniques are we going to use with topical meds? Clean the skin first, wear gloves and applicators too. What if the patient has an open wound when using topical meds? Sterile technique. What can you tell me about transdermal patches? Remove old patch before applying new. Document the location of new patch. Ask about patches during med history. Apply a label to the patch if it's difficult to see. Document removal of the patch as well, and wait 1 week before applying a patch to a previous site. What's the position when we're applying nasal meds that are in the form of spray? Sit upright, occlude one nostril, tip head forward, spray, sniff, and swab. Alright, for trying to do the nasal meds in the drop form, how are we going to get the maxillary and frontal sinuses? Head over edge of bed and tilt it side to side. How are we going to get the ethmoid and sphenocytosis? Head over edge of bed and straight back. Alright, what 2 things are we going to avoid when doing eye meds? Cornea, and then eyelids as well, with droppers or tubes to decrease risk of infection. Safety-wise, what are we going to do with eye meds? Use only on affected eye and never share meds. Alright, how are we going to store ear meds? Room temp to avoid vertigo and use sterile solutions. How are we going to give ear meds to a child? Pulling the pinna down. How are we going to give ear meds to an adult? Pull pinna up. So if patient has drainage with ear meds, what are we going to check for? Eardrum rupture. What is one thing we should never do when giving ear meds? Never occlude the ear canal. What is this position patient will be in if you're giving vaginal and rectal installation? Left lateral sims. Alright. What is the route? What's the steps we're going to do for vaginal and rectal installation? Lube, push point first, past anal sphincter, push against the wall, not in center feces, and let it absorb. They will melt. Alright, inhalation meds. Tell me about pressurized metered dosed inhalers. You need sufficient hand strength and hand-eye coordination, may be used with a spacer. Tell me about breath-actuated metered dose inhalers. Depends on strength and the patient's breath. Tell me about dry powder inhalers. Activated by patient's breath. What are irrigation meds used for? Cleansing an area, instilling a med, or applying hot or cold to an injured area. One would we use aseptic technique for irrigation meds. If there's a break in the skin or mucosa, when would you use clean technique for irrigation meds? When the cavity to be irrigated is not sterile, as in the case of the ear canal or vagina. What are the lure lock syringe? Lures are twisted on the tip and lock themselves in place. What are non-lure lock syringes? Needles slip onto the tip. Tell me, what are the three parts of the needle? Hub, shaft, bevel. Alright, how are we going to prepare injections from an ampule? Use alcohol prep pad and snap off ampule neck away from you. Put it on a flat surface. Aspirate med into syringe using filter needle. Replace filter needles with appropriate size needle or needleless device and administer injection. Alright. How are we going to prepare vial plus ampule meds? Prepare med from the vial first. Use the same syringe and filter needle to withdraw the med from the ampule. How are we going to prepare meds from vial to vial? Don't contaminate one med with another. Ensure final dose is accurate and maintain aseptic technique. What types of insulin we give? U500 or U100? Alright, do we want insulin to be clear or cloudy? You want them to go from clear to cloudy. Why don't we shake insulins? Bubbles will form, so roll between hands. Why do we administer insulin via injection? GI tract breaks down the insulin and destroys it. So what insulins are we not going to mix with any other type of insulin? Insulin glargine or Lantus, or insulin Dedimer or Levemir? Alright. How long do we have to give food to someone after giving insulin in pH? 15 minutes. Verify all insulins with another person. Alright. Is IM or sub-Q faster absorption? IM is faster, sub-Q is slower. What are the best sites for sub-Q injections? Outer, posterior aspects of the upper arms, abdomen, anterior thighs. What do we got to make sure about the skin before using subcutaneous injection? Free of skin lesions, bony prominences, large underlying muscles and nerves. Alright, what degree are we going to insert it at if we can grab 2 inches of tissue? 90 degrees, and 1 inch, 45 degrees. How much are we going to inject for a sub-Q for an adult? 2 to 5 milliliters, how children or older adult, thin patient. 2 milliliters, how small children, older infants, up to 1, and smaller infants, 0.5. Alright. What's the angle of insertion for IM? 90 degrees. What are the sites for IM injections? Ventrogluteal, vastus lateralis, and deltoid. Tell me about ventrogluteal. Gluteus medius, deepest and safest site for all adults, children, and infants. Recommended for volumes greater than 2 mils. Index finger, middle finger, and iliac crest form a V-shaped triangle. Insertion site is in the center of the triangle. Vastus lateralis, we know that one. So, specifically with aspirations, IM injections, what are we not going to do to reduce discomfort? We're not going to aspirate. What method are we going to use along with IM? Z-track method. It's a zigzag path, seals needle tract. Why would we use the Z-track method? It's used with meds that may caustic to skin or underlying tissue, or meds that need to stay in the muscle and can't come out. What do we use intradermal injections for? Skin testing like TB and allergies. What are the sites of intradermal testing? Inner forearm and upper back. What is the angle of intradermal testing? 5 to 15 degrees with bevel pointed up until small bleb appears. Alright. If we infuse IV fluids too rapidly, what may happen? They may OD and get fluid overload. Alright. What are the advantages of IV bolus? When the amount of fluid a patient can take is restricted. Why is the IV bolus most dangerous method for med admin? It's hard. You can't correct the errors. Tell me about volume-controlled infusions. Use small amounts like 50 to 100 milliliters of compatible fluids. What are some examples of volume-controlled infusions? Volume control administration sets, piggyback sets, and syringe pumps. What are the advantages of volume-controlled infusions? reduce the risk of rapid dose infusion by IV push, allow for administration of meds that are stable for a limited time in solution, allow control of IV fluid intake. Tell me about volume control admin. Small 150 milliliter containers that attach just below the primary infusion bag or bottle. What are the advantages of IV access or saline locks? Cost saving resulting from the omission of continuous IV therapy, effectiveness of nurse time enhanced by eliminating constant monitoring of flow rates, and increases mobility, safety, and comfort for the patient. For IV access or saline locks, what we can do before administration. Assess the patency and placement of the IV site. What are we going to do after administration of IV access saline lock? Flush it with the solution to keep it patent. Alright, fluid and electrolytes. Alright. Where's the thirst control mechanism in the brain? Hypothalamus. What stimulates the hypothalamus and thirst control mechanism? Increased plasma osmolality, decreased plasma volume, angiotensin 2 and 3, dry pharyngeal mucous membranes, psychological factors. What organs in the body control fluid output? Skin, lungs, colon, kidneys. What influences fluid output? ADH, RAS, and ANP. What is sensible H2O loss? You can see it like sweating. What is insensible H2O loss? You can't see it like breathing out. Okay, what are the signs and symptoms of hyponatremia? Coma, anorexia, lethargy, DTRs, limp muscles, OH, seizures, and stomach cramps. What are the symptoms of hypernatremia? Low-grade fever, high blood pressure, fluid retention, edema, decreased urine, increased tendon reflexes, and muscle spasms. What are the signs and symptoms of hypokalemia? Alkalosis, shallow respirations, irritability, weakness, arrhythmias, and weak pulse. What are the signs and symptoms of hyperkalemia? Muscle cramps, respiratory distress, chest pain, dysrhythmias, and oliguria. What are the signs and symptoms of hypocalcemia? Convulsions, arrhythmias, tetany, stridor, and spasms. What are the signs and symptoms of hypercalcemia? Bone pain, high heart rate, cardiac arrest, kidney stones, muscle weakness, and polyuria. What are the signs and symptoms of hypomagnesemia? Increased tendon reflexes, seizures, muscle cramps, tremors, and tachycardia. What are the signs and symptoms of hypermagnesemia? Muscle weakness, lethargy, bradycardia, decreased respirations, and hypotension. What is clinical dehydration a combination of? ECV dissipate and hypernatremia. All right. Is hypertonic 3% or 0.45%? 3%. What determines osmolality in the blood? Sodium. All right, what foods can we get phosphate from? Milk, processed foods, cheese, meat, seeds, and canned fish. What is the function of phosphate? ATP production. What foods can we get potassium from? Fruits, potatoes, instant coffee, molasses, Brazil nuts, spinach, beans, and fish. What is the function of potassium? Maintains resting potential of skeletal, smooth, and cardiac muscles. What foods can we get calcium from? Dairy products, broccoli, leafy greens, oranges, seafood, dried fruit, meat, beans, soy, almonds. What is the function of calcium? Influences the excitability of nerve and muscle cells and muscle contraction. What foods can we get magnesium from? Dark green vegetables, whole grains, avocados, bananas, nuts, legumes, and dark chocolate. What are the functions of magnesium? Works at neuromuscular junctions and is a cofactor for enzymes. All right. What is the solution of dextrose 5%? Isotonic. What is the solution of dextrose? 10%. Hypertonic. What is the solution of 0.225% NaCl? Hypotonic. What about 0.45% NaCl? Hypotonic. What about 0.9% NaCl? Isotonic. What about 3 to 5% NaCl? Hypertonic. What about dextrose 5% and 0.45% NaCl? Hypertonic. What about dextrose 5% and 0.9% NaCl? Hypertonic. What about lactated ringers? Isotonic. What about dextrose 5% in LR? Hypertonic. Okay. Too rapid or excessive infusion of any IV fluid has the potential to cause serious problems, especially be careful of potassium infusions because they may cause arrhythmias or death. What are we going to document when giving IV fluids? Site of insertion, number of attempts, flow rate, method of infusion, size, and type of catheter, time infusion started, patient response. What's phlebitis? Damage to the vein itself causes red streak down arm. What is infiltration? Leakage of fluid out of the vessel causing edema and redness. What is extravasation? Leakage of the vesicant medicine out of the vessel causing tissue damage. Alright, what is tissue integrity? The state of structurally intact and physiologically functioning epithelial tissue such as the integument and mucous membranes. What is granulation? Connective tissue that forms on the surface of a healing wound. What are the risks for impaired tissue integrity? Anybody really, but infants and children and older adults are greater risk. You got poor peripheral perfusion, malnutrition or obesity, dehydration or edema, impaired mobility, immunosuppression, exposure to irritants, and tissue trauma. What is the primary prevention of impaired tissue integrity? Skin hygiene, adequate nutrition, avoidance of excessive sun exposure, burn safety precautions, and dermal ulcer prevention. What's a first-degree burn? Partial thickness injury involving epidermis, normal skin barrier remains intact. What is a second-degree superficial partial thickness burn? Thin-walled fluid-filled blisters develop within minutes of exposure. What is a second-degree deep partial thickness injury? Involves entire dermis, appears waxy, white, and surrounded by superficial partial thickness injury. What is a third-degree burn? Full thickness injury, destruction of epidermis and often underlying subcutaneous tissue, bone and muscle may be destroyed. Wound appears dry and leathery. Let's talk about rule of nines. What is the percentage of the head? 9%. How about chest and abdomen? 18%. How about upper/mid/low back and buttocks? 18%. What about each arm? 9%. What about groin? 1%. What about each leg? 18%. All right. What are the risk factors for pressure ulcers? Impaired sensory perception, impaired mobility, altered LOC, shear, friction, and moisture. What is a stage 1 pressure ulcer? Intact skin with non-blanchable redness, discoloration, may be cooler or warmer than adjacent tissue. It's painful and firm. Was a stage 2 pressure ulcer? Partial thickness skin loss involving epidermis, dermis, or both. Wound bed is viable, pink, red, and moist. Granulation, tissue, slough, and eschar are not present. A serous/sanguineous filled blister may appear. Was a stage 3 pressure ulcer? Full thickness tissue loss with visible fat and granulation, tissue, and often epibole, which is rolling inward of the wound edges. Then tunneling and undermining may occur. What is stage 4 pressure ulcer? Full thickness tissue loss with exposed bone, muscle, or tendon, slough, or eschar may present, often has undermining. Was a deep tissue injury. Purple or maroon, localized area of discolored intact skin or blood-filled blister due to damage of underlying soft tissue from pressure and or shear. What is an unclassified pressure ulcer? If it has eschar on it, you may not tell how deep it is. It will be stage 3 or 4 when it's removed. Tell me about gauze dressing. Thin, transparent fabric. Apply as moist dressing with saline or dry dressing with enzymes and topical antibiotics. Delivers moisture and is absorptive. Tell me about a transparent film dressing. Traps wounds moisture over the wound. Ideal for small superficial wounds. Can remain in place for up to 5 to 7 days. Allows visual assessment of wound bed without removing dressing. Wound must have minimal to no exudate. Maintains moist environment and it offers protection. Tell me about hydrocolloid dressing. Maintains moist environment to facilitate wound healing while protecting wound base. Used for pressure ulcer stage 2 to 3. Tell me about hydrogel dressing. Gel used to regulate fluid exchange and relieve pain during wound healing. Can be covered with foam. Maintains moist environment. Used in pressure ulcer stages 2 to 3. Tell me about calcium alginate dressing. Used with large amounts of exudate. Packed into wounds. Turns to soft gel as exudate is highly absorbed. Requires secondary dressing. Used for pressure ulcer stages 3 and 4. Tell me about foam dressing. Protective and prevents wound dehydration, absorbs moderate to large amounts of drainage, can be used in combination with a hydrogel. All right, what are the factors influencing wound healing? Nutrition, tissue perfusion, infection, age, psychosocial impacts of wounds. What is a wound healing by primary intention? Wound edges are approximated like surgery. Risk of infection is low. Healing occurs minimally. Low scar formation as long as infection doesn't occur. Tell me about wound healing by secondary intention. It's like a laceration, carpet burn, or pressure injury. Risk of infection is high. Scar tissue takes a long time to form, and it does not have perfusion. Tell me about partial thickness wound repair. Inflammatory response, epithelial proliferation, and migration, reestablishment of epidermal layers such as scrape and abrasion. Tell me about full thickness wound repair. Hemostasis, inflammation, proliferation, and epithelialization. What's proliferation? The vascular bed is reestablished, the area is filled with replacement tissue, and fibroblasts proliferate. What is epithelialization? Surface is repaired and maturation occurs, sometimes taking more than a year. All right. What dressings? What is the status of a stage 1 pressure ulcer? Intact. What dressings are used for stage 1 pressure ulcer? None, transparent, or hydrocolloid. What do we know about using no dressing on a stage 1 ulcer? Open to air and allows for visual assessment. What do we know about using a transparent dressing of stage 1? Protects from friction and shear. For stage 1, what do we know about hydrocolloid dressing? It's for more serious ones, but it keeps wound moist, but doesn't always allow for visual assessment. All right, what is the expected change of a stage 1 pressure ulcer? Resolve slowly without epidermal loss in 7 to 14 days. What are the interventions for a stage 1 pressure ulcer? Turn patient, hydration, nutrition, pressure redistribution, chair with the cushion. All right, what's the status of a stage 2 pressure ulcer? It's clean. What dressings are used for stage 2? Composite film, hydrocolloid, and hydrogel. What do we know about stage 2 and composite film? Prevents shear and friction, but you cannot see it. What do we know about hydrocolloid dressings in stage 2? Change when seal of dressing breaks. Max wear is 7 days. What do we know about hydrogel dressings and stage 2 ulcers? Provides moist environment. What is the expected change to a stage 2 ulcer? Heals via reepithelialization. What are some of the interventions for stage 2 ulcer? Turn patient, hydration, nutrition, pressure redistribution, chair with the cushion, and then manage incontinence. What is the status of stage 3 ulcer? Not intact, but clean. What are the dressings we're going to use for stage 3? Hydrocolloid, hydrogel covered with foam, calcium alginate, gauze, growth factors. What do we know about using hydrocolloid and stage 3? Change when the seal is broken. What do we know about using hydrogel covered with foam in stage 3? Used when there is significant exudate covered with secondary dressing. What do we know about calcium alginate in stage 3? Wound has lots of exudate covered with another dressing. What do we know about gauze in stage 3? Unfolded to make contact with wound, soaked with saline gauze. What do we know about growth factors in stage 3? You're going to use this with gauze. What is the expected change of a stage 3 ulcer? Wound heals via granulation and epithelialization. What are the interventions for stage 3? Turn patient, hydration, nutrition, pressure redistribution, chair with a cushion, manage incontinence, and evaluate pressure distribution. Real quick, what are we going to do for evisceration of a wound? You're going to put saline-soaked gauze on the wound and then prepare to send the patient back to surgery. All right, what is the status of stage 4 ulcer? It's a clean wound. What are the dressings we'll use for stage 4? Hydrogel covered with foam, calcium alginate, and gauze. What are the expected changes of stage 4 ulcer? Heals via granulation, scar tissue formation, reepithelialization. What are the interventions for stage 4? May need surgery. All right, what do we know about the status of an unstaged ulcer? Wound covered with eschar. What are the dressings for unstageable wounds? Enzymes, adherent film, gauze, plus order solution, or none. What do we know about unstaged ulcers and enzymes? Break down eschar and provide debridement. What do we know about adherent film and unstaged ulcers? Soften eschar. What do we know about gauze and ordered solution and unstaged ulcers? Deliver solution, wicks, wound drainage. What do we know about no dressing and unstaged ulcers? It's rare. If eschar is dry and intact, no dressing is used, allowing eschar to act as a cover. What do we know about the expected change of an unstageable ulcer? Eschar lifts at edges as healing progresses. Eschar loosens over time. What are the interventions for unstaged ulcer? You may need surgically. All right, see you back in 2 weeks. Blanch urethra gets white when you put pressure on it. Looking over 30-60 minutes before dressing changes, potentially with pain meds. No hydrogen peroxide. Clean to dirty. Clean to dirty.